Hey, good morning. Today I'd like to discuss with you highlight and the treatment of rectal cancer and the important treatment, clinical scenario and evidence-based scenario that help us in the decision making regarding the management of our patient with rectal cancer. Primarily, we can define the rectum as the lowermost part of the GIT and part extend from 4 centimeters after the anal verge and the anal canal up to 12 centimeter and 15 centimeter in different literature reviews. We can consider rectal part of the GIT as high, mid and low rectum by centimeters, and we can consider the function preservation and the organ preservation is an important issue and important goal in the management of rectal cancer. Treatment with multimodality therapy is really important, and the last 2 decades we can define the update in the treatment of multimodal therapy regarding the proper staging, the proper addition of surgery together with concurrent chemoradiotherapy in order to improve the local regional control and to improve and minimize the possible recurrence status. We can also define what's called the sphincter preservation and possible neoadjuvant treatment in the form of total neoadjuvant treatment in order to minimize the possible recurrence and maintain organ preservation. Thus, the rectal carcinoma in the recent advance, we can define the sphincter saving procedure up from 15 up to 50% with no colostomy, overall 5-year survival from 30% up to 60%, and the depth of invasion decreased from 40-60% with adjuvant radiotherapy. We can define also the lymph nodal status as one of the major parameter or criteria for the risk group population to define the addition of chemotherapy or radiotherapy. And now we can define what's called the molecular biology or molecular analysis, the imaging, the surgery, the possible chemoradiotherapy at the recent advance in the treatment. What about FAB gene mutation or mismatch repair gene mutation and non-polyposis colorectal cancer? All of these, one of the entities will guide us for proper screening program for high risk population, for the patient family history, and selective group population by age. Also, how to improve the surgical approach of prophylactic surgery, prophylactic proctocolectomy as one of the treatment options for these patients with selective gene mutation. Thus, we can consider and conclude that they will develop rectal cancer or colon cancer later in these life stages. The patient approach, important, this is a history and clinical examination. We can define the possible pathological review after proper colonoscopy and colonoscopy, and the marker like carcinoembryonic antigen, complete analysis of molecular pathway, and how to use the rectal protocol MRI to define the mesorectal invasion, the presence of lymph nodes, and selected if there is any peritoneal disease or lymph node aggregation or whatever in the region. Full lab also, and chemical hepatic profile is an important issue, CT chest in the advanced stages disease. We can use chemotherapy and radiotherapy as neoadjuvant or adjuvant entity in patients with poor histology, patients with extramural spread, or with involved lymph nodes. But there is selective specific criteria for the treatment option according to the clinical scenario, clinical situation, the T&M staging of the patient. In stage 1 resectable primary with no metastasis, we can go for transanal excision. We can excise with a proper safety margin. This will improve the local regional control and function preservation in very early stage disease when the patient actually presented very early in the disease. While we can consider patients who will not eligible for transanal excision or mesorectal excision, we can consider the more invasive surgery like low anterior resection or abdominoperineal resection and the use of colostomy, either it will be temporary colostomy. One of the major rule in the treatment of with multimodality treatment is to minimize the poor quality of life cause of permanent colostomy. That's the neoadjuvant entity, the total neoadjuvant treatment. The possible sphincter preservation option is one of the goals of the multimodality treatment with rectal cancer. In unresectable with no metastasis, we can consider chemoradiotherapy as a definitive treatment, while in stage 2 and stage 3 disease also neoadjuvant therapy with radical surgical resection, low anterior resection, in order to avoid abdominoperineal resection. A selected group population, we can define also these patients for low anterior resection. Metastatic disease, we can consider also the radiotherapy, while in oligometastasis we can define selected group population will be possible for surgical resection, while there is an oligometastasis and not extensive metastatic disease. The radiation therapy play a major role, as we said, in the treatment of rectal cancer. Thus, in European short-term radiotherapy, it was the primary management of the rectal cancer, while in the United States, the post-operative chemoradiotherapy was, as adjuvant setting, was the standard treatment for them. And what is the real indication for radiotherapy in the rectal cancer? Actually, to minimize the recurrence and improve the local-regional control by percentage and percentage, and to downsize the low-lying tumor, attempt to more frequently perform sphincter saving surgery. In sphincter saving procedure, we can consider the neoadjuvant treatment, and then we may consider very efficient surgery with low anterior resection and sphincter preservation, or to downsize the tumor in primary irresectable tumor, making it resectable. يبقى thus, in order to improve the local-regional control, in order to improve the sphincter saving procedure, or making irresectable to resectable disease. We have so many different clinical scenarios, and we have different also evidence-based scenarios, like the Swedish rectal cancer trial was conducted as the first one of the major study, which significant benefit of neoadjuvant radiation compared to surgery alone was found. Actually, in short course even fractionation, we can define very high significant p-value regarding the local-regional control and improvement of the local-regional control with minimizing the recurrence with p-value highly significant. This is a neoadjuvant radiotherapy versus surgery alone in the Swedish trial. In the Dutch trial, we can define additional preoperative short course radiotherapy, total mesorectal excision, reduce the local-regional recurrence from 11 to 5% only with highly significant p-value also. Thus, the addition of chemotherapy, the addition of radiotherapy prior to surgery will improve the local-regional control with highly significant p-value instead of the only using surgery, and thus we can define the addition of radiotherapy preoperative in two major of the clinical trial, the Dutch and the Swedish trial. There is also other trial, but what we can say, the real value of the addition of radiotherapy in neoadjuvant setting actually is not the improvement of overall survival. Actually, it is the improvement of the local-regional control, and there is no very great difference in the treatment with short course fractionation versus long course fractionation. Actually, we can consider the possibility of rapid surgical intervention. We may control with short course fractionation and to add this fractionation prior to surgery within 1 week, or even to continuous long course chemoradiotherapy, and to make the patient possible for low anterior resection after the whole treatment. The difference may be in the toxicity profile and not the local-regional control actually, or the treatment efficacy. Now we can consider also in the clinical practice, we may consider both of them actually effective and efficient. However, there is specific and selective indication for from the clinical point of view in short course radiotherapy and long course, not competing but complementary strategies with